But there's people live streaming.
Right.
I was gonna say, I just, you don't have to give it, there's only me.
With live stream, because I can't, right?
We can discuss amongst ourselves.
Do you know if anyone's in the session live stream?
It looks like Keisha's the only one so far. Is that correct? Still have one viewer.
Forcing them to give their presentation.
I said, does no one want to learn about the flu?
We have 5 now.
Oh,
So the show must go on.
who's right on there?
There's still a lot of
Live
people that
stream.
are congregating though.
I just don't know how the filtering discussion is gonna work with virtual audio.
Well, I think that we should talk about the rates.
Oh, yeah,
I'll do
yeah.
that as well. And if you have ideas. Fine. Bet Jessica does.
Jessica does.
I bet Jessica.
How does it improve?
I bet she has a lot of ideas.
I'm not a food person.
You're not a
A food person.
neither am
You don't mind, is that what you said?
I. No, I said neither am I.
Oh, okay.
Okay. Should we give it a few more minutes, or do you want to go ahead and get started now?
Doesn't matter.
But like literally, if I'm the only person, you don't have to be able to talk.
Looks like
Well,
there's
it's-
5 people online,
Oh.
so.
And it's being recorded for
Oh,
anybody
sure.
who wants to, so.
gotcha.
Okay, we can go ahead and start. All right. Hello, online people. So all sessions are being recorded and will be available for viewing up to 3 months following the conference using the links in your agenda and calendar invites. Materials available for the session are provided by the presenter. I'm going to go ahead and introduce our 2 amazing presenters here. This is our first session in the Improving Patient Care Through Data track, and this will be focused on influenza vaccines. Our first presenter is Dr. Harry Brown. Dr. Brown is a retired captain in the U.S. Public Health Service. He spent over 26 years in uniform, and all of his career was spent in the Indian Health Service. He attended the University of Texas Medical Branch in Galveston, Texas, and completed a residency in family medicine at the Medical University of South Carolina in Charleston, South Carolina. He is board certified in family medicine. He served as the chief medical officer for the Nashville area from 2007 to 2014, and as acting chief medical officer for the Billings area for 2015. Dr. Brown currently works as a hospitalist for the Eastern Band of Cherokee Indians in Cherokee, North Carolina, and as a medical epidemiologist for the United South and Eastern Tribes in Nashville, Tennessee, as part of their Tribal Epidemiology Center. Brian Hendricks is an employee of the United South and Eastern Tribes Tribal Epidemiology Center for almost 10 years as the Quality Improvement Data Analyst. In this position, Brian is responsible for the GIPRA Improvement Pilot Project, Immunization Program, HIV and Harm Reduction Program, and the Project ECHO program. In these programs, Brian conducts training and webinars on the electronic health records, resource and patient management system, iCare, national immunization reporting system, and multiple state immunization registries. Brian is an alumnus of Middle Tennessee State University, where he received both his Bachelor of Science in Statistics and Master of Science in Biostatistics. In addition to these degrees, Brian is also certified in BASE, SAS, and Technology of Participation, and is currently working to be certified in Public Health. Dr. Brown and Brian, thank you for being here today, and I'll go ahead and turn it over to you.
Anna, thank you very much for that introduction, and welcome to our amazing audience, both here in person and online. I was just talking to Dr. Ann Bullock out in the hall, who unfortunately is giving a talk right this minute, but I would like to be attending. Ann was saying this is the first talk she's done in a long time with a live audience, and I actually can't remember the last time I did a talk with a live audience. So after 2.5 years of doing nothing but giving talks, well, I've done lots of things besides giving talks, but all the talks I've done have been on SARS-CoV-2, the COVID pandemic. So finally, I get to talk about a different virus, influenza. Although Friday, Brian and I put together a talk on monkeypox. So it's kind of fun doing something different for a change. So if you'll go to the first slide, or just the second slide.
Would you like to click your own slides, or you want me to?
Oh, that's an option.
Yep, you just click it.
Right?
Yep.
Not used to that. Is it the right or the left?
There you go.
Must be the right. No, that's the left. I'm also, I also get my left and right mixed up. Right. So we're going to talk about influenza and influenza prevention, basically, or influenza vaccine, and some strategies to improve our rates of influenza vaccination. But along the way, we'll talk about the disease, how to diagnose it. There are some treatments for it nowadays. But the picture on the left there was taken in 1918 or 1919. And I believe the picture was taken somewhere in Europe. It's not from the US, but anyway, that was, of course, the great influenza pandemic of 1918, which actually didn't stop in 18. It went on to 1919, 1920. And there were actually, yearly epidemics of influenza all through the 20s. So pandemics don't usually get over in 6 months or a year. So what we're living through right now is not unusual. So the influenza virus is actually pretty similar to coronavirus. I mean, there are different families. The influenza virus is in the orthomyxa virus family. That's not important. It's just, one of those things that it's kind of interesting, but it comes in 4 different types, big types. There's A, B, C, and D. Type A is the one that typically causes epidemics and pandemics. It's found in a lot of different animals and birds. So, there are lots of different things that can get influenza A. Influenza B only occurs in humans and does not typically cause pandemics, but we do see it just about every winter. It tends to be mild, and we see it a whole lot more in kids than in adults. Influenza C is also very similar in the kind of disease it causes. It causes respiratory tract disease, but it is so mild that it's not usually picked up. You know, we don't test for it typically. You know, people don't get hospitalized with influenza C. So we probably don't even know how much there is of it around because it's not that clinically important. And then influenza D only happens in cows, so it's not important to humans. So you can see that it's actually quite a bit structurally like the coronavirus. It has these spikes, except in influenza, it's an RNA virus, just like SARS-CoV-2. But the spikes are called hemagglutinin, and then there's another surface protein called neuraminidase. The reason it's maybe important to talk about that a little bit, you all hear about H1n1 H3n2. These are sort of major subtypes of influenza A. And the H and the N are hemagglutinin and neuraminidase, and they're found on the surface of the virus. Hemagglutinin is the way the virus actually binds to our cells and gets inside. And then neuraminidase does several things, but its major function is to help the virus get out of the cell. Once it goes into our cells, it replicates, makes thousands of copies of itself. And then neuraminidase helps it to escape and go infect other cells. So those are two places that you might try to make a drug or a vaccine or something that would stop it. So it's important to talk about antigenic drift and antigenic shift because these are the things that are responsible for influenza coming back year after year after year. Because if influenza never mutated and never changed, we'd all be immune to it eventually and it wouldn't be a problem. But influenza has every year just about has these minor mutations. That's called antigenic drift. But every once in a while, there'll be something called antigenic shift. When this happens, we usually have either an extremely large epidemic or we have a pandemic. So in 1918, antigenic shift occurred and the H1n1 came about. Prior to that, there was something called H8n8, which we never see anymore. But that caused some big pandemics in the late 1800s. We only know about that now because they've been able somehow to go back and test specimens from people that died way back then. It's amazing what they can do now. But anyway, this is actually caused when two different types of viruses, usually one from a human and one from a bird, infect a pig. And the genes trade with each other and a totally new subtype comes out. So that's antigenic shift. So it's spread person to person by respiratory droplets, very similar to COVID. It's a major cause of hospitalization and death. Varies a lot, but in any given year, we may have anywhere from a low of 140,000, maybe up to a high of 700,000. So a lot of hospitalizations. Then typically in the US, and these are statistics from the last 10 or 20 years actually, but we'll have anywhere from 12,000 to 60,000 deaths a year, but the average is about 38,000 a year. So as you can see, you know, it's pretty significant. Most of these deaths happen in people over the age of 65. 80% of them do. The other group that's really at risk are the under 2-year-olds. Under 5-year-olds get complications, but especially the under 2-year-olds, which is why it's really I think it's very important to vaccinate that population. So in the temperate latitudes like where we live, or if you went to South America, say Argentina and Chile, it tends to be a seasonal disease. We have it in the winter. Whereas in the tropical latitudes, you see it all year round. That probably is due to environmental factors, people in the temperate zones, when it's warm, we're outdoors. In the wintertime, we tend to be crowded inside. So that's the major reason for that. Interestingly, though, we've been seeing influenza A this summer. I had a patient a few weeks ago who I hospitalized with influenza A. I didn't believe it. I said, this got COVID. But they tested her for COVID, it was negative. The influenza A test was positive. And so I tested her for COVID again, still negative. Tested her for influenza again, and was still positive. So I think she really did have influenza. And then I went and read about it, at least, and I actually called Jorge Vera. I said, are you seeing influenza? He said, yeah, we are, so. Very strange. But anyway, this is like the last 40 years when we see influenza cases in North America, or actually just the United States. But so you see there's a little bit starting in October, November, then it really goes up in December, but February is when it tends to peak. And then it pretty quickly falls off, and by April, we're not seeing it anymore. So what about pandemics? We've had several in the 20th and 21st century, 5 to be exact. And just about every time, if you notice, the death rate has gone down over time. Why is that? Well, probably number one, people were just generally healthier. But number two, we have treatment and prevention that we did not have back then. So what does it look like? Well, typically, people are contagious usually a day before symptoms start, which is a bad thing because you don't know you're sick, but you're spreading it around. So this is why influenza tends to be such a common disease. But you can be contagious up to about 5 days after the onset of symptoms. That also is kind of similar to COVID. The incubation period is usually an average of about 2 days. So once you're exposed, you tend to get it really rapidly. If you've had an exposure in your past 4 days, you're probably not going to get it. Classic symptoms are similar to COVID, fever, body aches, headache, sore throat, non-productive cough, all that kind of stuff. Now, in older adults, something that they often present with are not the classic symptoms, but they present with altered mental status. So, it's just a good thing to keep in mind. Anytime you see an elderly person with altered mental status, you might want to think about checking them for influenza. So usually people have pretty bad fever, high fever up to maybe 104, 105 even, for about 3 days. And then they get better. Cough can go on for 4 weeks, but they're not infectious. So most people recover on their own, no treatment, just, rest and fluids and that kind of thing. But some people get complications. You can get a secondary bacterial pneumonia that needs to be treated with antibiotics. But one of the dreaded complications is influenza pneumonia, because that tends to be fatal. That's a very serious complication. Myocarditis is pretty common. And then encephalitis and Guillain-Barré are 2 complications that we see. Have people heard of Rye syndrome? No? Okay. I have not seen a case in probably 30 years, 35. I think the last time I saw a case of Rye syndrome, I was in residency. So This is why you don't give children aspirin. There are two diseases that kids tend to get. One is chicken pox, the other is influenza. That if they take aspirin with those two viruses, there's this thing called Rye syndrome that they get very sick, they often go into a coma. Sometimes they die. They're almost always, if they survive, they almost always have brain damage from it. So it's a really bad complication. But we just don't see it anymore because people know not to give little kids aspirin. So there are a number of groups that are at increased risk for these complications. They're adults over 50 or kids under 5, but especially the under 2-year-olds. Pregnant women, back in the H1n1 pandemic in 2009, 2010, one of the groups that was the most highly impacted were pregnant women. Had quite a few women who died from it, who were pregnant. But anybody, the typical chronic disease, chronic lung disease, heart disease, kidney disease, liver disease, neurologic disease, because they may have, respiratory impairments. Diabetes is a risk factor, of course, immunosuppression. People who are very overweight, and then the usual, the usual victims, people that live in congregate settings, especially the elderly in nursing home. The last thing on this list, American Indians and Alaska Natives. For some reason, it's not well understood. Our population is at higher risk of complications. During the 1918 pandemic, there were entire villages in Alaska where every single person in that village died from influenza. And indeed, in the 2009 pandemic, we saw increased rates of complications and deaths in our population. So how do you diagnose it? Well, usually it's the winter time. We say the flu's going around, and you see a person with typical symptoms, they probably got influenza. Lab tests are usually not all that helpful. They're usually fairly normal. But there are several confirmatory tests you can do. Viral cultures, nobody does those because they're impractical to do. They take a long time. There are PCR tests now that are commonly available, but they're more expensive. And then there's some rapid tests like the Abbott ID that can detect influenza. But the most practical, least expensive are the rapid antigen tests. You're probably familiar with those. Very similar to the tests we do, the home tests and rapid antigen tests that we do for COVID. And then this last point, it's very important to make sure nowadays that it's influenza that you're dealing with and not COVID, because they're treated. So speaking of treatment, how do you treat it? Well, most people do fine with just supportive care, but there are some antivirals. The one that we commonly use, oseltamivir, you might know it as Tamiflu. It's good if you get it within 48 hours of the onset of symptoms. After 48 hours, it's probably not going to do much good, but it prevents replication and hopefully people recover faster. These other drugs are rarely used because this one's an oral tablet, oseltamivir. Zanamivir, good drug, but you have to inhale this powder. Nobody wants to do that. Peramivir is a newer one, but it's only IV. And then there's a really new one, aloxavir. And it is an oral drug, and it's a single dose, which is, of course, very convenient. But you can't use it in immunocompromised people. It's also not very available because it's a brand new. But it may become more common. So, as we all know, an ounce of prevention is worth a pound of cure. Yes, Steve?
I have to ask a question.
Yeah.
I have had flu in the past and the provider has prescribed me an antibiotic. Is that a common practice in, test the flu?
Unfortunately, yes, that's common practice, and it's worthless.
That's what I was wondering.
Unless you have pneumonia, you know. But
Can it decrease the onset of pneumonia?
No.
No?
No.
That's what I thought.
but you know, there are doctors out there that everybody who, okay, going way back to the 40s or 50s when penicillin became readily available. If you went to the doctor with any infection, you got penicillin. That's why penicillin became a fairly useless drug. It's because everything became resistant to it. There are still doctors out there that everybody that goes in with a sniffle or anything else, you know, they get a Z-pack. That's just what's done. It's bad practice. But I can't speak to your specific
I got a
situation.
feedback and I said, well, this is horrible.
It's for the flu, right? Yeah.
So I have a question back on testing.
Sure.
Having flu prevalent now with COVID, along with others, would it not be best to do the PCR 4-panel test, the test for flu A, B, COVID, and RSV, just
Yes.
to rule everything out at once? Even though it's
That's a great question, and I think the answer to that is yes, because that way you're testing for everything at once.
Okay.
So yeah, and you bring up a very good point. Thanks for bringing that up. You can, if your lab will agree to it, and if you have the machine to do it, there are these 4-panel tests that test for influenza A and B, COVID, and RSV all at the same time. So yeah, I mean, all of those can have the exact same clinical presentation, the exact same symptoms. So you don't know what you're dealing with unless you test it.
Right.
Yeah, it's a very good point. How do I get rid of that?
And I guess to follow on to that,
Yes.
my providers are pushing for just doing the antigen test, the added ID or the molecular for COVID. But now they're wanting to bring in the same thing for flu. Should we just test for COVID to see quickly if that's what it is, then go to a PCR test, or to test the whole panel, or?
Yeah, there are a lot of strategies, and I don't know the right answer. I think the right thing to do is to sit down and work out the cost effectiveness.
Okay.
And also, it may actually depend on what you're seeing in the community at that time. If you've got a huge outbreak of COVID, I would say the thing to do is test first for COVID. If that's negative, then test for the other things. But if you're seeing both, you know, if it's winter, you've got influenza and COVID going on, maybe the 4-panel test would be the thing.
Okay.
Especially in kids.
Yeah.
Because
You just don't know.
RSV in adults is usually not serious, but in children it can be very serious. So influenza vaccine, this is one of the first, maybe it was the first viral vaccine ever developed. It's developed in the 40s, been around a long time. They first used it in World War II to prevent soldiers from getting flu. This picture here is from the 1950s. And can you see? Those are eggs. They're inoculating the eggs with influenza virus and having it grow inside the egg. And this is how the inactivated vaccine's been produced for decades. It's grown in eggs, then they take it out, purify it, they inactivate it, the virus, with usually something like formalin, and then they make it into a vaccine. So you inject this basically dead virus, but your immune system sees it, makes antibodies. That's how it works. That's the only thing we used to have. It was really simple to give a vaccine talk, but now we got a whole bunch of different vaccines. So I'll go through them. So it used to be that all of our vaccines were trivalent. They were usually had 2 types of A and 1 type of B, but now they're all quadrivalent. They have 2 Bs instead of just 1. And that's really a good thing because B usually comes in 1 of 2 flavors. It's either the Victoria strain or the Nevada strain. And in any given year, it's a little hard to predict whether it's going to be one or the other or both. So now they just hedge their bets and put both. But other kinds of vaccines besides, and nowadays too, rather than the whole virus, for the last 20, 25 years, they've actually split out the antigenic parts of the virus. So you don't get the whole virus, you just get the parts you need for your immune system to make antibodies. So those tend to have fewer side effects, so that's good. But there is one type of vaccine we now have that's grown in cell culture. There are no eggs involved. It's all mammalian cell culture. There's another kind of vaccine that's made that's a recombinant vaccine. So it's basically, they have a virus or yeast or something, I can't remember now what it is, but they put in the genes for the influenza hemagglutinin, and then that produces a whole bunch of hemagglutinin, and that's what they make the vaccine from. So it's a very purified kind of vaccine. And then, of course, there's the nasal vaccine that you can only use in age 2 to 49. You can't use it in people 50 and over, can't use it in people under 2. It's usually a really good vaccine. There was one year, a few years ago, that for some reason it didn't seem to work well. It kind of got a bad rap because of that. Excuse me, but since then it seems to have worked pretty well. So it's a live attenuated virus, so and it's squirted up the nose, and that's how we typically get influenza. So the live nasal vaccine helps you to develop mucosal antibodies that tends to help you not get it as much. So most of the time, this vaccine is actually a better vaccine, but occasionally it's not. So anyway, what's a person to do when you have so many choices? Well, usually if you're in the age group 2 to 49, you offer people this one. If they're not in that age group, you give them the inactivated vaccine because it's much cheaper and readily available. These are nice, but they're not really any more effective. So I'm not saying there's no place for them. Some people like to use those in people who have egg allergy, but I'm going to talk more about egg allergy in just a minute. So again, who needs to get the vaccine? Well, there used to be this long list of people that needed to get influenza vaccine. It was a very long list. It was hard to keep every, you should give it to everybody 65 and older. You should give it to everybody who has this condition, that condition. But sometime back in the early 2000s, the CDC just said, just give it to everybody who's over 6 months. Why don't we give it to people under 6 months? It's because they don't respond to it. Basically, their immune system is too immature to make antibodies from the vaccine. So we don't use it in them. The best time of the year to give it is in September and October. Now, just because it's past Halloween doesn't mean you don't give it to people. You can still give it. It's a good thing to do. But if you're really going to prevent influenza, you need to give it before. Yes.
We had a debate the other day in the clinic as to whether or not to do it in late September or wait till October. And everyone was kind of like, in late October, it's a better vaccine because they could have made adjustments to it as opposed to the one in early September. Is that?
I don't think that that's true.
Okay,
Usually the decision on the composition of the vaccine is made by, an expert panel with the FDA and CDC.
okay,
Once the decision's made, that's the vaccine that's manufactured. They usually do not have the capability to tweak the vaccine in mid-season. It's not like baseball where you can bring somebody up from the minor leagues in the middle of the season. So the timing, the reason I say September to October, after about 6 months, the vaccines tend to lose their effectiveness. And you want to carry people through March. So if you back up 6 months, September.
Right.
So in some ways, the later you give it, the better, because it'll last all the way through the winter. But remember, sometimes we start seeing cases in October. So, that's why the timing, September is probably actually optimal, but I really think there's kind of a 2-month window there to really focus your attention on giving it to as many people as you can. Now, again, if people didn't get it in September, October, they show up in November, December, and they haven't had it, strongly encourage you to give it to them. This is a point I really want to make. For years and years and years, we ask everybody, are you allergic to eggs? And they say, yes, you can't have the flu vaccine. Well, that's a myth. Even though it's grown in eggs, there's almost no egg protein in the vaccine. If there's any there, it's in tiny, tiny, tiny amounts. There were actually 2 big studies done a few years ago in people that had documented egg allergies, gave 1,000 people, 1,000 plus people, regular old flu vaccine, not a single one reacted to it. Kind of surprising, and I don't know why, but this is not well-known information, and we're still asking everybody, are you allergic to eggs? But you can actually give any of the inactivated vaccines to people with egg allergies. So there are some adverse effects. Probably everybody in this room has had a flu vaccine and you had a sore arm or you didn't feel good. I used to dread my flu vaccine. Every year I'd get the flu vaccine. The following day, I felt like dog do. I was achy, I was tired, just didn't feel good. Now, a lot of patients will tell you, I took that shot one year and it gave me the flu. Next day, I had the flu. Well, no, you didn't. You had the typical, adverse effects. You can't get the flu from the inactivated vaccine. It's a dead virus. You really can't get it from the live one either. But, a lot of patients think that. There is this shoulder bursitis. It's very rare. But some people have actually gotten a frozen shoulder after getting influenza vaccine. It was most likely due to poor technique. You're supposed to give it in the deltoid, about here, and not up here, where it could actually get into maybe the subacromial bursa and give you a bad bursitis that leads to a frozen shoulder. I actually have a physician colleague that I work with who 2 or 3, 4 years ago had this complication. And for 6 months, he couldn't use his shoulder in that arm. It's pretty bad. So I put 3 question marks next to Guillain-Barré because there's a lot of controversy, even among experts, as to whether or not influenza vaccine can cause Guillain-Barré. The best evidence says there may be a tiny, tiny, slightly increased risk of Guillain-Barré, but that increased risk is very, very small. And if you look at the studies that have been done on it, the confidence interval straddles 1, so maybe not. If it happens, it's an extremely rare event. However, influenza itself raises your risk of Guillain-Barré syndrome about 9 times. So getting influenza is a much, much higher chance of giving you Guillain-Barré than getting the vaccine for influenza.
I have a quick question.
Yes, ma'am.
So my mother had polio and I always encourage her to get like the flu vaccine, shingles vaccine, that sort of thing. But she is very much against it for fear of that. Can you speak to that at all?
Yeah. Her chance is virtually zero. I mean, she's got a much higher chance of getting Guillain-Barré because she didn't get the influenza vaccine and she got influenza. So, I mean, that's the quick and simple answer.
That's good. Good enough.
Having had polio years and years ago doesn't make her more susceptible from the vaccine.
So if you had a parent that had Guillain-Barré, should they get the vaccine, or are their offspring more predisposed of getting it from an influenza, or?
I don't think anybody knows the answer to that question. Yeah, you know, this all started way back in 1976 when there was an outbreak of H1n1. And we had not seen H1n1 in decades. And when it happened in 1976, there was this huge fear that we were gonna, you know, it was 1918 all over again. It turned out that that particular strain of H1n1 was not nearly as virulent. But there was kind of some panic. They rushed out a vaccine. It was probably poorly made and not well purified. And there were some cases of Guillain-Barré. And even though there's still to this date some argument about whether or not there were excess number of cases of Guillain-Barré associated with that vaccine, I think most experts believe that, yeah, there was a slightly increased rate of it. But anyway, ever since then, you know, there's this fear out there that influenza vaccine causes Guillain-Barré, and it's probably completely unfounded. Well, Brian, I think it's your turn. Does anybody have any questions about the vaccine or influenza? Okay, so this is part of the talk is going to be Brian Hendricks' show. Yep. And we're going to talk about vaccination rates.
Yes. So this is the vaccination rates for national area. 2018 to 2021, the target was 29% for roughly 29% for both 6 months to 17 years and 18 plus. We fell short every year. Then they dropped it to 19% for both of them. And we're closer. So that's our rates for the national area. They were high in 2020, but obviously they dropped. So with that being said, we need to figure out some ways to increase vaccination rates. So I want you to think about what one program event that you attended that was successful with getting tribal citizens involved. Just take a minute or two.
Can I ask a quick question?
Yes.
What are the vaccination rates for the other areas? Like how does the national area compare to the other areas?
I don't know. I have that stuff.
Yeah.
I can tell you historically, and this is going back 10 years ago. We were kind of right in the middle.
Okay.
So we were somewhere around the 50th percentile.
Right.
But I don't know if that's still true. We actually had slightly higher rates 10 years ago.
So what was one program event that you can think of that was successful with getting tribal citizens involved? We'll go around the room. I'll give you a minute, then we'll go around the room and we'll share.
Can I start?
Sure.
Okay. So I work for the Eastern Band of Cherokee, and years ago we instituted this drive-through vaccination program. So a couple, 3-4 days during September, October, we have these drive-through where people can actually just drive up in their car. They don't even have to get out of the car. You just kind of hold your arm and you get your flu shot. So that's been really successful at getting lots of people vaccinated.
So this isn't a tribe specific example, but thinking of experiences I've had, most people say, "Oh, well, it's very inconvenient for me to have to go to the doctor to get the flu shot and this and that." A lot of the hospital systems I've been in, and schools I've been involved with their school health programs is with the schools, they take it to the students each year, but then also the clinics and the hospital systems, instead of the staff person having to take time out of their schedule, they will have that staff nurse go around to every single person in the hospital and just continue to do rotating, visits until they pretty much exhausted everyone. And they'll do that for a period of a couple weeks to where it's not making people have to try to figure out how to go get it, but just bring it to them in convenience of, oh yeah, I'm sitting here charging, go ahead.
No, this doesn't have to be, that's a great idea, but this doesn't have to be specific to vaccinations. This can be anything, like a 5K around HIV or
Like a festival or powwow.
festival or powwow, something. Yeah.
Festivals and powwows.
No, doesn't.
Basketball games.
Yeah. Yeah. I think that we may be having the county health department come to work and give vaccinations.
That's what we are, when we were in, they were coming.
Yeah, we have a community health nurse that goes to our childcare programs. So we have like after school programs for Native children and then in the summer camps. But what applies to the season that we vaccinate, she'll just go to the after school programs and then Head Start. And then also all the tribal administrative buildings, so like the Longhouse. She goes around our clinic and, vaccinates the employees. So that's been helpful, but there's been a lot of hesitancy the last year or so.
I see that too.
Where are you from?
I work at the Catawba Service Unit,
Okay.
so in Rock Hill, South Carolina.
Seen patients there many times.
Yeah, awesome.
It's been a long time.
Yeah, I actually used to work at Cherokee at the hospital there prior to this job.
Okay.
Yeah, it's all.
What were your COVID vaccination?
Insurance.
Just
In the area.
Oh,
Do you have access to the last report of the vaccination rates in your email?
Let me see.
Let's say
I can tell you they're pretty variable.
it depends.
Yeah. They're
Some are good,
really
some are-
variable. We have some tribes that are really, really high, and we have others that are not. Tends to be the ones, this is a gross generalization, but if you just look at the numbers, the ones in the Northeast are higher than the ones in the Southeast. Big strides, right? And where are you from?
Virginia, Upper Mountain,
Which one?
Upper Mountain.
So how did that success of that program make you feel? I want you to reflect on that.
Mine made me feel convenient. It's convenient, it's what I like.
Anybody else? Do we have any comments from the?
I'm not seeing any questions or comments online. I do have the USET aggregate report for COVID vaccines. Looks like for the whole US, we're at about 67% for fully vaccinated. For IHS, about 42.5%. And then reporting facilities in the IHS Nashville area, 53.3%. But I don't have the breakdown for each tribal nation.
If you're interested.
I'm on it.
Here's the first one. Perfect timing.
The COVID vaccine rates.
Oh, yes, I'm actually was just working on those.
Perfect.
This is Imani, she's one of our other epidemiologists. She's the one that does the reports.
It's just interesting that like your COVID vaccine rates, aggregate average were much higher than your flu vaccine rates. And so I mean, you can learn from COVID, right? What's going on with COVID. But also, I'm just curious, I thought everyone was doing flu and COVID together.
Obviously, we're not.
Yeah.
Yeah,
I don't know I don't know if it's vaccine fatigue or what the hesitancy is, but at our clinic, it's been hard to get people, like we'll actually have people that will get the COVID vaccine, but they don't want the flu. I don't know.
I mean, I guess that's my partner.
what kind of vaccine do you use? Do you use the nasal or do you use?
I think we use both. I know that, well, I know we use both because last year, some people opted for the nasal and some people got the shot, so.
I would love to get the nose spray.
Yeah, I've never done the nasal.
I've never done it either. And I can't get the vaccine because it freezes up my shoulder. No, I don't get bursitis, but I can't move my shoulder for a week. So I get swollen.
You should get the nice.
That's what I told them. They're like, we don't care.
You can come to Qatar.
I need to. So moving on, what was the thing or things that made the event so impactful and successful?
Well, if it's like a festival or a powwow or something like that, and you're celebrating your culture and there's a lot of community involved with that. So it's something that most people that attend, it's something they very much value. That's obviously helpful.
And you're meeting people where they are.
Mhm.
What was one thing that you would or could change to make it even more successful?
I want to administering it. Sometimes we get the ones that really don't want to be doing it, as we always said in the ER, the grumpy patient nurses. And it was like, okay, jab.
Yeah.
Nurse ratchet.
How can you incorporate those parts into a program for increasing influenza vaccination rates? The good and the bad. Getting providers that actually care about giving the vaccine.
Where they don't give it too high, you know.
True.
Okay.
Meeting people where they are, going to events that celebrate tradition and culture.
I think probably for the tribes that that do have good immunization rates or COVID or rates or immunization rates for COVID is the community mobilization part. You know, like you think like the tribe was involved, the tribes may have given incentives, you know, the tribes made declarations of mask wearing and all of this. So I think that when you have the community leadership behind something as well, it takes that even further. So it'd be really cool to get, you know, tribal leadership more actively involved in influenza stuff too.
I definitely agree. And it's funny because you said that the ones that are higher in our area, they're all the same. It's all mostly the same rates. 30% lower.
You made a very good point about getting providers on board with it. So all the years that I was a chief medical officer, either in Nashville or in Billings, all the chief medical officers usually would meet 4 to 5 times a year. The most heated discussion that we ever had in our group was over whether or not we should mandate influenza vaccine for IHS employees. There were some of the CMOs who were really, really pro-vaccine, and there were a couple that were not for it at all. You know, we can't mandate this. And their argument was not illogical. Their argument was that the vaccine is not all that effective. And it's hard to argue with that. Did you notice I did not speak to the effectiveness? Does anybody wonder how effective this vaccine is? The answer as to how effective it is depends on a couple of things. The main thing is how well they predict what's going to be circulating that year. In a year where the virus that actually is circulating and the vaccine are matched well, the effectiveness can be as high as 70 or 80% at preventing infection. The years where there's a bad match, it can be close to 0. You know, it's 30 or less. So the effectiveness of the vaccine varies from year to year. But the thing that it does do, and is shown to do pretty well, is to keep people from dying from influenza. So that's why I think it's a good thing to do. But it does cut down on transmission. And the nasal vaccine is, in a lot of years, is as high as 80%. So if you give the nasal vaccine to all the kids, the school-age kids, because they're the ones who have the highest attack rates and are the most responsible for spreading it. So if we could get a very high, if you were gonna, you know, really target your campaign, vaccinate all the people in the nursing home and all the kids in school. And if you could do that, you would go a long ways towards preventing, you know, influenza.
What about the patch? I know that they were working on a patch. Or that they had a patch, and it wasn't successful 1 year, they just stopped making it. Do you know anything about it?
I really don't know anything.
Because I know that has like little teeny tiny needles that.
Yeah, you know, all kinds of crazy things. You can actually get, there is a flu vaccine that you can give with a jet injector. You know, no needle involved. You just have this jet of fluid that shoots into your arm. That actually causes more sore arms and more problems than sticking a needle in. So I would never get the jet injected vaccine. But, you know, it was made in an attempt to not have needles. Yes.
I think one thing, and kind of looking back over COVID, like flu and having leadership buy-in and, you know, whether it's travel leaders or just, you know, national leaders in general, it's important, but I also think that there's a lot of value in getting those grassroots organizations and community organizations buy-in and to try to mobilize that, because, you know, COVID, even at the tribal level, it was, well, it's all about politics, about tribal politics, you know. There's, you know, new administration coming up, so, you know, they're trying to do this or that. Whereas if you get those grassroots organizations on board, and they can really mobilize the community, which is, I think, one thing that we saw with COVID is the distrust in the leadership at the national level and even at the tribal level.
I don't have anything else. I really don't have any solutions. I was just like to get ideas flowing.
I do have the COVID-19 vaccination rates for USET membership available to address that question. So the percentage of population fully vaccinated as of last week was at 53.3%. And then the percentage of those fully vaccinated that have received another dose was at 19.1%. And we do those reports monthly for the USET aggregate. And we have we've thought about including flu data with these reports, but we have not incorporated them, but it may be a good idea to maybe start considering that again.
Flu season.
Yeah, as flu season comes upon us.
Well, thank you so much. If you have an evaluation, go ahead and fill it out, and then you can drop that at the registration table. Thank you.
Yeah, thanks for your attendance.
We had 9 viewers online.
Okay. Thanks to the online.